Pharmacology, anticonvulsants. Medications used for seizures are called anticonvulsants or anti-seizure drugs. Anti-seizure drugs stabilize cell membranes and suppress the abnormal electrical impulses in the cerebral cortex. These drugs prevent seizures but do not provide a cure. Anti-seizure drugs are classified as CNS depressants. There are many types of medications used to treat seizures, such as phenytoin, phenobarbital, benzodiazepines, carbamazepine, valproate, and levetiracetam. There are three main pharmacological effects of anti-seizure medications. First, they increase the threshold of activity in the motor cortex, thus making it more difficult for a nerve to become excited. Second, they limit the spread of a seizure discharge from its origin by suppressing the transmission of impulses from one nerve to the next. Third, they decrease the speed of the nerve impulse conduction within a given neuron. Some drugs work by enhancing the effects of the inhibitory neurotransmitter gamma-aminobutyric acid, or GABA, which plays a role in regulating neuron excitability in the brain. Gabapentin, although structurally similar to GABA and classified as an anticonvulsant, is commonly used to control chronic neuropathic pain. Neuropathic pain is defined by the International Association for the Study of Pain as pain caused by a lesion or disease of the somatosensory nervous system. An example of neuropathic pain is tingling or burning in the lower extremities that often occurs in patients with diabetes. Phenytoin. Phenytoin was discovered in 1938, was the first anti-seizure medication, and is still being used to control seizures. Mechanism of action. Phenytoin improves evidence of seizures by interfering with sodium channels in the brain, resulting in a reduction of sustained high-frequency neuronal discharges. Indications for use. Phenytoin is indicated for the treatment of tonic-clonic or grand mal and psychomotor or temporal lobe seizures, and for the prevention and treatment of seizures occurring during or following neurosurgery. Considerations across the lifespan. Phenytoin should not be administered to pregnant women because it will cause harm to the fetus. When given intravenously, there is a black box warning that the rate of administration should not exceed 50 milligrams per minute in adults and 1 to 3 milligrams per kilogram per minute, or 50 milligrams per minute, whichever is slower. In pediatric patients, because of the risk of severe hypotension and cardiac arrhythmias. Careful cardiac monitoring is needed during and after administering intravenous phenytoin. Phenytoin has a narrow therapeutic drug level, usually between 10 to 20 micrograms per mil, so serum drug monitoring is required. Serum levels of phenytoin sustained above the therapeutic range may produce confusional states referred to as delirium, psychosis, or encephalopathy. Accordingly, at the first sign of acute toxicity, serum levels should be immediately checked. Abrupt discontinuation can cause status epilepticus, so in the event of an allergic or hypersensitivity reaction, rapid substitution of alternative therapy may be necessary. Use with caution in patients with renal or hepatic impairment. Elderly patients may require doses adjustment. There are many potential drug interactions with phenytoin. Read drug label information before administering. Phenytoin is extensively bound to plasma proteins and is prone to competitive displacement. Phenytoin is metabolized by hepatic cytochrome P450 enzymes, so it is susceptible to inhibitory drug interactions, which may produce significant increases in circulating phenytoin concentrations and enhance the risk of drug toxicity. Adverse side effects. Serious and sometimes fatal dermatologic reactions, including toxic epidermal necrolysis, or TEN, and Stevens-Johnson syndrome, SJS, have been reported with phenytoin treatment. The onset of symptoms is usually within 28 days, but can occur later. Phenytoin should be discontinued at the first sign of a rash. Drug reaction with eosinophilia and systemic symptoms, or DRESS, has been reported in patients taking anti-epileptic drugs, including phenytoin. Some of these events have been fatal or life-threatening. DRESS typically presents with fever, rash, lymphadenopathy, and or facial swelling in association with other organ system involvement. These findings should be immediately reported to the provider. Acute hepatotoxicity has been reported with phenytoin. These events may be part of the spectrum of DRESS or may occur in isolation. Hematopoietic complications, some fatal, have occasionally been reported in association with administration of phenytoin. These have included thrombocytopenia, leukopenia, granulocytopenia, agranulocytosis, and pancytopenia with or without bone marrow suppression. The most common adverse reactions encountered with phenytoin therapy are nervous system reactions and are usually dose-related. Reactions include nystagmus, ataxia, slurred speech, decreased coordination, somnolence, and mental confusion. Patient teaching and education. Patients should be advised to take medications as directed and that doses should be evenly spaced throughout the day. It may take several weeks to obtain the desired medication effect. Abrupt withdrawal of medication may cause status epilepticus. Patients should avoid alcohol and other CNS depressants while taking anticonvulsant drug therapy. Additionally, diabetic patients should monitor their blood glucose levels carefully. Now let's take a closer look at the medication grid for phenytoin. Levetiracetam is indicated as adjunctive therapy in the treatment of partial onset seizures in patients 12 years of age and older with epilepsy. It is generally well tolerated. Mechanism of action. The exact mechanism of action is unknown. This medication may interfere with sodium, calcium, potassium, or GABA transmission. Indications for use. Levetiracetam is used for partial onset seizures in patients with epilepsy. Nursing considerations across the lifespan. Plasma levels can gradually decrease during pregnancy and should be monitored closely. Safety and effectiveness in pediatric patients 12 years of age or older have been established. Levetiracetam immediate release in solution can be used in patients as young as 1 month. Levetiracetam should not be stopped abruptly or withdrawal seizures may occur. Use with cautions in patients with renal impairment. Adverse side effects. Behavioral abnormalities, including psychotic symptoms, suicidal ideation, irritability, and aggressive behavior, have been observed. Monitor patients for psychiatric signs and symptoms. The most common adverse reactions are somnolence and irritability. Advise patients not to drive or operate machinery until they have gained sufficient experience on levetiracetam. This drug can cause anaphylaxis or angioedema after the first dose or at any time during treatment. Serious dermatological reactions, including Stevens-Johnson syndrome and toxic epidermal necrolysis, have been reported, as well as coordination difficulties and hematologic abnormalities. Patient teaching and education. Medication should be taken as directed and may cause increased dizziness and somnolence. Patients, family, and caregivers should also monitor carefully for suicidality during medication therapy. Now let's take a closer look at the medication grid for levetiracetam.